So I'm here to talk to you about three things today. The Access Care study, which has been working with LGBT people at the end of life. Also our work reviewing the evidence on the experiences of LGBT people in bereavement. And also a collaborative study we've been working on the experience of healthcare for key populations in Zimbabwe. So those are the three things I'm going to touch on with you this afternoon. So we'll start off talking about the UK context. So estimations of LGBT populations in the UK. It's estimated that about 5 to 7% of the population identify as lesbian, gay or bisexual, and that's some data from the DTI and the government when they were developing the Civil Partnership Act. And it's estimated, and there's not very great data on this, it's estimated that about 1% of the population identify as trans. It's important for us within healthcare services to remember that sexual orientation and gender reassignment are protected characteristics within UK law under the Equalities Act. And in terms of identifying and improving health outcomes for LGBT people, this has become an increasing area of health services research. And in fact, there was a really great editorial in The Lancet earlier this year that called for an end to health disparities and discrimination for LGBT people in terms of their health outcomes as well as their access to appropriate health care. So why may there be health disparities for LGBT people? Well, first of all, I'm going to walk you through some of the evidence that suggests that as a result of discrimination, minority groups actually experience more health risk behaviours. And also, once people have health needs and they enter the healthcare system, there's an inadequate response from healthcare professionals due to some of their attitudes and skills towards LGBT people. There was a large study published last year in the Journal of General Internal Medicine which used the UK primary care research study. It was a study of around 2.5 million people, and it concluded that within the UK, not only do sexual minorities have poorer general health, so they rate their general health worse, but they also have less satisfaction with the primary care experiences that they've received within the NHS. There was also an interesting study published in the American Journal of Public Health last year that showed that amongst heterosexual healthcare providers, they do have a preference in terms of their behaviours for heterosexual patients. So there is certainly discrimination out there, whether that's withheld within attitudes or acted out in behaviours is yet to be seen. But when we look at what's happening within the NHS with respect to LGBT health, the main focus, if you look at NHS resources online, the main focus is on primary care, mental health and sexual health. There's an interesting study in the American Journal of Public Health that suggests that within the US there is greater all-cause mortality for LGBT people within the US compared to heterosexuals, and also that there's a higher lifetime risk for certain cancers amongst LGBT people, and also that sexual minorities are less likely to attend for routine cancer screening. And Ken Meyer, who's a professor at Stanford and runs a large LGBT health program there, has reviewed the evidence of risk behaviours linked to the experience of discrimination, and he has reviewed the evidence demonstrating that there are higher rates of alcohol use, cigarette consumption and drug use amongst LGBT people, which are directly linked to experiences of discrimination. And our whole work with Access Care has been founded on this systematic review that we published 4 years ago now, and we reviewed the evidence for needs, experiences and preferences of sexual minorities for end-of-life and palliative care. Now you can read this paper, so I'm not going to give you great detail about the paper now, but the basic findings from our review were that palliative and end-of-life care environments tend to be heterosexually biased. There was a perceived lack of support for people from sexual minorities and a failure to involve partners in those moments of critical decision-making. And what was very interesting from this systematic review is there were no studies actually conducting face-to-face interviews with LGBT people at the end of life. These tend to be proxy interviews or interviews with bereaved caregivers. So what might be good practice for LGBT people within our health service? Well, there's this very nice guidance from the Health Equality Index, which states very clearly that it's important for healthcare facilities to provide patients the opportunity to be identified as LGBTQ in their health records if they so wish. So we need to make that opportunity available for people to self-identify. And of course, in the world of palliative care and in the NHS more generally now, we're interested in person-centred care. And I found this nice definition from the Health Information Network in South London from last year that defined person-centred care for us. And they say that it's considering people's desires, values, family situations, social circumstances and lifestyles, seeing the person as an individual. And the underlying principles to achieving person-centred care are getting to know the patient as a person and recognising their individuality. And I'm sure that all of us within this room would agree that if you know somebody as an individual, you know their lifestyle, their family situation, that includes understanding their sexual identity and their gender history. It'd be very difficult to achieve person-centred care without knowing that about the person before you and the people around them. In palliative and end-of-life care, we're often seeing older people, and I think it's very useful to just briefly look at what's happened in a fairly rapid space of time. We've gone from the late 1960s, when homosexuality or sexual acts between men were decriminalised over the age of 21 in private. In the late 80s, we had Section 28 came in, Stonewall's been set up, restrictions on serving in the army weren't lifted until 2000, age of consent going down to 16 at 2001, then we have the repeal of Section 28, then we have civil partnerships, then we have Gender Recognition Act for trans people, then we have the 2010 Equality Act, which I referred to, which outlaws discrimination, and then finally in 2014, same-sex marriage. So the point here is to remember that older people have seen a lot of change, and they'll have lived a long period of their life under highly discriminatory law, and we need to remember that. So the three things that I'm going to talk about today, access care and related studies, is first of all our original data from our UK-wide study of LGB and/or T people with advanced disease, then our systematic review of bereavement experiences of LGBT people, and then briefly touch on a collaborative study that we've been working on with key populations in Zimbabwe. So those are the three things that we'll touch on this afternoon. So first of all, access care, which was funded by Marie Curie, and we're very grateful for that support. And also one of our great partners has been GMFA, a community-based group. So what did we aim to do with access care? We wanted to develop and disseminate evidence-based mass media resources with the LGBT community to increase both the demand for appropriate end-of-life care, let people know what they should expect and what they should ask for, and also through training resources to improve the supply of appropriate end-of-life care by developing some training resources and integrating those within existing curricula for healthcare professionals training in end of life. Because, of course, what we don't want to do is set up an LGBT palliative care course, because the people that need that training are the ones that aren't going to attend. So in terms of the objectives, we had three phases. First of all, conducting qualitative interviews with LGB and/or T people with advanced disease and their caregivers. Then to integrate that novel data with the evidence from the systematic review that I showed you just now to develop some mass media resources, drawing on our multidisciplinary project group. Then to do some field testing of those resources and develop them into mass media resources which can go live, and to disseminate those widely through LGBT media. And then lastly, in the third phase, to develop the training resources and to integrate those in training courses around the UK and monitor the impact of those through uptake and numbers attended. So in terms of who we're including in this study, our inclusion criteria are adults who identify as LGB and/or T, people with advanced disease, so we're using, for the clinical settings of recruitment, using the one-year surprise question, and the caregivers of those adults who are facing the end of life. We had two recruitment sources, first of all through the national media, and we had incredible support from community groups. Also through emailing listings of LGBT groups around the UK, through Twitter, we had gay press interviews, we had radio interviews, we had massive coverage of this. And then in terms of the clinical sites for recruitment, we recruited through the clinical teams at King's, Guy's, St Thomas's, St Joseph's and Trinity. Our purposive sampling frame aimed to generate a purposive sample with maximum variation according to age, sexual identity, gender history, primary diagnosis, relationship status and geography. Because I think it's important to recognise that your experience in Brighton or central London may be different to experiences in more rural areas. And it's important to really acknowledge just how grateful we are for the massive amount of community engagement here. These are all the community groups that have promoted our study. It was quite remarkable. The community engagement with this topic has been phenomenal. And if any of you are interested on how we achieve that community engagement, Marie Curie asked us to write a blog on community engagement for Access Care, and you can read that blog there. So we recruited and conducted in-depth interviews with 40 people. You can see from the right-hand side that we did indeed manage to recruit people from around the UK. We recruited 19 gay men, one man who identified as homosexual, one gay intersex man, 13 lesbian women, 2 bisexual women, a partner of a bisexual woman, 2 trans lesbian women, and a friend or caregiver of a trans woman. So in total, that gave us 20 patients, 6 informal carers and 14 bereaved informal carers. They were mainly white, around half were cancer, and the non-cancer were mainly organ failure and neurological conditions. And really, helpfully, we managed to get a nice range of ages. So the youngest person we interviewed was 27, the oldest person we interviewed was 94. So interviews were transcribed throughout the data collection period, which allowed us to read through the transcripts and iteratively refine our topic guide throughout the study so we could focus down on emergent, interesting themes. All of those interviews were imported into NVivo so that we could conduct the analysis using a thematic approach. First of all, we coded a random sample of 5 interviews from our 40, and a second researcher double-coded them. Following agreement on that code, the code was presented to the steering group. Once that was agreed, we applied the code to the entire data set, and then over time, if we needed to split or merge codes, we did that with further consultation throughout the study group, just to make sure that we had unified definitions of our codes and internal consistency of all our codes as we developed and applied the coding frame. So, what did people tell us? First of all, people talked about being visible. And these are perceptions of how visible people felt within a palliative care and hospice service. They do a lot of articles from the point of view of a male partner. You know how he's coped with that kind of thing and how his sex life. There's a big assumption that you've got some supportive male partner. So I think if you're single at all, if you've got another kind of partner, then it's hard because of that assumption. I would ask them to look at their literature. There's also quite an assumption that you want to look beautiful somehow to make yourself feel better again, which is nothing really to do with sexuality. But I do think it assumes heterosexuality in a way. There's a lot of emphasis on makeup and come for a pamper evening and this kind of thing, as if you'll feel better if you look better somehow, which I suppose is a byproduct of heterosexuality. I wish that the literature and everything was a bit more geared towards us. And this is an older woman living with breast cancer. And in terms of people's preferences and experiences for sharing their identity, whether that be their gender history or their sexual identity, when somebody was asked what change would have made the biggest difference to his care, this older gay man living with prostate cancer said, well, to be recognised that I'm gay, to be understood that I'm gay, and I've got feelings about being gay. I like to be accepted. So it's not very much to ask, it's just a simple level of acceptance of his sexual identity. And when asked by this older gay man living with cancer, when asked whether healthcare professionals should actually ask him about his sexual identity, he said, I would tell them. If they asked me, I'd tell them. I have no hang-up after all these years in the closet. You heard the hinges creak all over Europe when I came out. So he's very, very comfortable. If you ask him, he will willingly tell you. But of course, it needs to feel relevant to the care experience. If it's pertinent to reveal, I will reveal definitely. I don't mind being asked directly, as long as, if I detected it's more personal curiosity, I will use the mind your own business response, or why do you need to know? If there's a reason for why you need to know, then you need to know. So it's really important you explain to people that we try to deliver person-centred care, and that's about understanding the person as a whole, including their sexual and gender identity. Very different view at the bottom here. No, because I don't think it's anyone else's business what you are. If you want to share it spontaneously, then that's okay. So it's about making it possible for people, but maybe not requiring people. It's about facilitation. Somebody of my age, my longer experience is one of hiding my sexuality and not acknowledging that in a formal way. So there's always at the back of your, well, certainly at the back of my mind, there's always a concern that somebody will be negative about you, make judgment about you. So you spend a lot of energy trying to work out at what point in the conversation do you actually acknowledge and do you state your sexuality. It's not usually about the individual per se, it's about the risk assessment around that. So it's about people deciding what's going to be the cost or the benefit of making this judgment. And this woman, of course, is 53, she's seen some changes in her life, so actually it's not always been an easy thing to identify her sexuality, and maybe she feels that there's a real threat, a risk, rather than benefit from revealing it. And what are you going to do as a service if people do experience discrimination? What's going to happen? Yeah, it's all very, very important to me to know that there are policies and procedures in place so that we are actually protected. So if something did happen, you know that actually. That's not okay. So this person wants to know that if she does have a poor experience, that you're actually going to remedy it. The world has changed so much, but I'm sure there are still lesbians who are uncomfortable and not confident. And it's about how do you reassure them that it's fine, you are going to be treated the same. Just be open, because we've made sure that the professionals are not going to have a problem with that. And if you do have a problem, then this is who you talk to get it sorted. If you're not brave enough to challenge someone, because not everybody is. So people have got to feel safe and secure. So what about individualised care? What does it mean for the people we spoke to? This is a very interesting situation for this older trans woman living with lung disease. Taking estrogen increases the risk of blood clots. So now I've got these blood clots. I had a conversation with a consultant. The logical thing to do is to stop taking them to reduce the risk to a minimum for the future. So then we had to talk about how important it was psychologically. And I said that I think it's very important. I mean, if someone said your heart will stop in 10 minutes if you don't stop taking them, I'd stop. But I had to work with the gender clinic people, and they said there is an elevation of the risk, but it's acceptable. It's easy for someone else to say it's acceptable, I know, but so we carried on. So in this context, this woman's gender history is really, really important. It does become part of clinical decision making. And in terms of people's psychosocial needs, this person says it feels that society doesn't validate the loss of a civil partner quite as much as they would understand and validate the loss of my husband. It's more complicated, and a lot of people don't have the imagination to understand that it's the same kind of relationship. So this woman was fearing that actually her relationship isn't valued and understood in quite the same way as if she'd been in a heterosexual relationship, and that's her fear. So what about future care? Where do people want to be at the end of life? I really don't want to go into a place where, you know, I'm the only gay guy or, you know, gay person. It's just, you know, there's nothing wrong with straight people, but it would be so nice to be in a place where, you know, I could reminisce about ex-partners instead of having to listen to the endless conversations about their children and their grandchildren. It's very nice, I'm happy for them, but that's not my world. So this is about a fear of somebody actually finding a place where their story is going to fit. So what are the kind of barriers that get acted out in clinical encounters, and what are the stresses that that might cause within a clinical consultation? One of the big problems that people talked about was the assumptions that are enacted within a clinical conversation. It's usually been, if they're sort of getting background, they don't ask you about your sexuality, they ask you about your heterosexuality, which is saying, I'm heterosexual and I wonder what your experience of heterosexuality is. And it's perfectly fair, it doesn't offend me or anything like that, but it says I'm different. Basically, it's referring to sexuality as sexuality when in fact it's heterosexuality. And it's speaking in ways that assume that you already share that sexuality, rather than coming at the topic with an open mind that you might be gay. So this is all about heteronormative assumptions in the language we use and the procedures that we use, and the assessment tools that we use. And there are, of course, some examples of very poor practice. And I'll share this one with you. There was complete lack of recognition. The consultant, even on the 10th or 20th time of being told I was his partner, still referred to me as his brother. There's no official next of kin because it's same sex, and there's a lot less desire to be flexible. So these are two fairly young men, and they repeatedly explain to the consultant their relationship, and it's not acknowledged. And then, of course, people have different individual preferences about terminology. I think if someone's using homosexual because of academic rigour, then I'm perfectly fine with that. I think if someone's using the word homosexual as a pair of tongs to keep it at a distance, then of course you sort of shrug your shoulders. It doesn't hurt them, but you feel a bit sorry for them. So people need to be enabled to ask what people's preferred terminology is, and then to be able to use that back to them. And that was one of the biggest things that's come out of our dissemination. We've now spoken to about 600 people in training around the UK, and one of the biggest things that we get back from this data from training clinicians is we don't know the right words to use. That's what we need. We need help in opening these conversations. Lack of sensitivity and transphobic behaviours were also quite concerning from our respondents. Probably three occasions when somebody's used the wrong pronoun. I think culturally it's probably a difficult concept for him to grasp. I think he read that I wasn't taking my health seriously. Then he called me Mr. or referred to me as Mr. to his underlings around the bed, and I took exception to it. He did it again, and I just thought, I just don't care anymore. So I launched at him, telling him I didn't think his qualities as his interpersonal skills were any good. This is an older trans woman living with ILD. Another trans woman with COPD said, I've been in resus where I didn't know if I was going to survive the event or not, where it has 10 bays with 10 patients, just with curtains. And you can hear every conversation. Some doctors have said to me, how long have you been transgendered for? And everybody has heard. And as much as I can't breathe, I'm like, what the fuck? And I'm lying there. I don't want to be talking like this. Do you know what I mean? And they've got no right to say that out loud in front of all the other patients. So we have to have the balance between actually ending discrimination towards people from sexual minorities and trans people, but at the same time treating people's information with confidentiality. So what does good care look like? We did hear examples of good care, or what good care should look like. Making identity a non-issue. That's what's described by a number of patients. Expect to be treated equitably. Expect to be treated as a couple. There's something about having the confidence for it not to be an issue, because you don't want to have to deal with that as an extra worry, as an extra concern, as something that inhibits anybody asking questions or getting the right kind of answers. And I think this is what's echoed in our kind of feedback sessions with the clinicians about having the confidence to use the right language and to ask these questions comfortably. And good practice around asking the relationship. Good care is when people don't feel embarrassed to ask you questions. So if they wanted a classification of are you lovers, they ask it. Clarity is important. Good care is where it's not patronising, it's practical based, but it's soft. So patients want clinicians to feel empowered and comfortable to be able to have these conversations. I was absent once because I was doing a course of my own at the time, running in tandem with what was going on at home. I needed to be at college to do a presentation. I couldn't be there for one of her appointments. The surgeon asked where I was and why I wasn't there and that kind of thing. So yes, it was noticed when I wasn't there. So good practice does exist, and I think that's important that we kind of demonstrate some of that as well. So in summary from the access care data, patients are happy to disclose if they feel there's relevance, and then there's gain in disclosing that aspect of their identity and not risk. But unfortunately, even after disclosing to clinical staff, practice doesn't always recognise that relationship. So once it's disclosed, I think it's really important that we retain that information and that we recognise it. It's important that we reflect on our language, our materials, our approaches, and that we try and reduce presumption of heterosexuality in the way we communicate and in the images and the materials that we have around us. And we also have to remember that people will often have a history of discriminatory experiences. So we have to remember that the patient may be bringing fear of discrimination into the room, and that may be actually hampering some of your communication efforts. So briefly now from access care, what was clear from the small number of bereavement reviews we conducted, that bereavement is a really, really important issue, and there's a lot of disenfranchised bereavement. So we conducted this systematic review, which was published earlier this year. And again, I won't go into great detail, but of course there were some generic experiences within these papers. Bereaved, people talking about a loss of a partner leading to pain, orienting towards the loss of their partner, then reorienting to being single and feeling continuing bonds to the person that's passed. But also there were some very specific additional barriers and stresses that you can read about in this review. Some poor experiences of care around the time of death, complex issues of legal and financial problems. And of course for gay men, and particularly older gay men, the shadow of HIV/AIDS, people that have been through the dreadful days of large numbers of loss related to HIV and AIDS. Actually a lot of that can chime when they have subsequent bereavements. And getting appropriate professional support that recognise relationships as important, being able to work with different social and family support structures and understanding the community context in which somebody lives is really very important. And Catherine, who conducted this review with me, modelled some of the evidence from this bereavement review. From the 23 articles on LGBT bereavement experiences on 13 studies, we can kind of very basically map all papers onto this. Is the relationship spoken or is it unspoken? Is the relationship accepted or not accepted? So if you're spoken and accepted, you've got overt acceptance. If it's spoken but it's not accepted, you've got overt exclusion. If accepted but we don't talk about it, so kind of covert acceptance, it's unspoken. If it's not spoken about and it's not accepted, we've got utter invisibility of that relationship. So overt acceptance gives us nice talked about acknowledged relationships. The problem with unspoken acceptance, so the kind of covert acceptance, is that you don't end up, of course, exploring the partner's bereavement needs. If you've got overt exclusion, then you get people excluded from the bedside or from funeral arrangements. And if you've got utter invisibility, then you have complete lack of social recognition of the person's loss as a widow. It's interesting, when we looked at the bereavement literature and in the LGBT context, there are enormous gaps in the literature. Mainly the research has been carried out in large urban areas. Most of the research is focused on the experiences of gay men. Bisexual people very poorly represented, trans people completely absent in the literature. The idea that it's LGBT is actually stated in the study title, but it rarely is. Sexuality is often poorly described, so you get 25 LGBT people as if there are some kind of group of people with a shared identity. Most of the research is on white middle-class LGBT people. There's very little on minority ethnic groups. Very little research into how experiences like faith and ethnicity and culture may shape your bereavement experiences. And also, of course, in these studies, there's likely to be quite a lot of selection bias because you're attracting those who have already identified their sexual identity to the research. So lastly, I'd like to talk just for a couple of minutes about a study that's been conducted in Zimbabwe, which has been a kind of collaborative study alongside Access Care. And I just briefly want to draw your attention to this study. This is a map by the International Lesbian Gay Association looking at lesbian and gay rights in the world. Red means we've got the worst situation for LGBT people in terms of legal rights. So we're going all the way from the death penalty here, if you're LGB, all the way through to the best situation where we've got equal same-sex marriage in these green countries here. The little white spots are where there are actually anti-discriminatory laws in place. So we can see there is huge inequity in the world. And actually there are large parts of the world in which being lesbian, gay or bisexual is a very real danger to your survival. So this study was led by Jenny Hunt, collaborating with Access Care, and was funded by one of our funders here at the Institute, the Open Society Foundations in New York. And this study aimed to investigate attitudes and experiences of key populations. Key populations is a term that's often used in the HIV research world. It means sex workers, men who have sex with men, and lesbian, gay, bisexual, transgender and intersex people. They interviewed these key populations, palliative care providers and health workers, to talk about accessibility and the quality of health and palliative care for these key populations. And I have to warn you, the data is quite hard. So Jenny conducted a number of focus groups. She interviewed 60 people in focus groups of between 5 to 10 people. And interestingly, because there are quite a large number of sex workers in a study, this compared to the LGBT studies, we have many more women in this sample. They're mainly Shona people, a few Ntebele people. And we can see that we've got lots of sex workers, about 15 gay men, and smaller numbers of lesbian women and transgender people. And then 15 in-depth interviews, again, which were with healthcare staff and mainly Shona people. So the three main themes from the Zimbabwean data. First of all, illnesses are caused by bad behaviour, that LGBT people or key population sex workers bring illness on themselves through their sexual behaviour and they deserve blame, not compassion. The second main theme, that actually your access to healthcare, and including palliative care, is conditional on you conforming to the perceived sexual norms for that country or for that healthcare provider. You have to pretend, deny or lie about your identity or your behaviour. And actually the third main theme was that the healthcare that you receive is determined by the personal attitude of healthcare providers rather than the professional ethics under which you'd hope they'd operate. So first of all, bad behaviour, deserve what they get. This palliative care nurse said, there's a prostitute that lives down the road there who's now having HIV and AIDS. She used to take other people's husbands. Most people will say, let her suffer, it's her time now. She used to make others suffer, so it's her time. So actually this is a welcoming of somebody's suffering rather than our usual palliative care mantra of reducing suffering. This sex worker said, they say we're doing something illegal, which is prostitution, so you won't get the medication. They won't give you the medication when they have it. So this is actual refusal of treatment. And another palliative care nurse talking about lesbian and gay people said, this is a taboo, an abomination. What are you doing? No wonder you are in this situation. So highly, highly blaming language. People talked about lying, hiding and pretending so they could actually access the healthcare to which they have a perceived right. They would ask where your partner is for them to do the tracking system. So I could not take my girlfriend to the clinic with me, and I would take any man on the road to go with me so I could get treated. And then this nurse talked about how they identify people. Our social history just goes to, are you married? If yes, then we take it they have one sexual partner. As a nurse, I have never had anyone telling me directly that they are gay. Never. So I think this really tells us about the culture in which people feel able to identify themselves. And the hospice administrator said, so it's very hard for them to speak about their sexual identity and we don't ask. We generally assume that everyone is heterosexual. So that's the kind of the presumptive way of operating. And then personal attitudes of the healthcare providers are absolutely key. I was going for a regular HIV test, and when I went there I decided to tell the counsellor that yes, I am a gay person, and the whole session changed. It was no longer about my HIV status or my results or anything. It was now a sermon on how wrong my lifestyle is. It's no longer an issue of health to say you are healthy or having a healthy lifestyle. It's now what they think about your sexuality. And this palliative care nurse was very, very clear on her views. In the first place, I think to be lesbian or gay, it's a sin. I think it emanates from how I understand the Bible. My view comes biblically that it's a sin. We do talk about palliative care as a human right. We are within the development world now, so money through DFID and research monies are all trying to develop to support these sustainable development goals. And goal 3 is that we ensure healthy lives and promote well-being for all at all ages. But I think we can see very clearly that at the service level, it really isn't care for all. And the WHO resolution to the World Health Resolution on Palliative Care, which was passed in 2014, very clearly recognises the human right to palliative care. So it's really important that we remember that all people have the human right to palliative care, irrespective of their gender identity or their sexuality. And so just the last few quotes when we think about palliative care as a human right. This palliative care nurse says, they can be killed or burnt alive because people regard them as animals and not as human beings. And this gay man said, I've come to seek treatment, basic treatment, as a citizen of the country as enshrined in the Constitution. But when you go there, the way that the health professionals treat you is different. So I think we've got a long way in some contexts for LGBT people and key workers actually being able to claim any healthcare rights as a human right. So summary from the Zimbabwean data, we see lots of evidence of moral judgment, blame, curiosity about people's sexual behaviours, very clear discrimination, and actually to the point of withholding treatment, which is enormously concerning. And if you want to access care, you may have to remain undercover, you have to pose as somebody you're not. And it's very much about healthcare workers, and there's great ignorance about people's lifestyles and use of inappropriate language. And it's very interesting when you look at Jenny's data, there's very, very little support from the family, let alone the healthcare services, and most of it is coming from other members of the key population groups. So there's lots of informal care to support people, which is an enormous amount of care when people are being turned away for treatment. You can imagine the implications of that. So, conclusions from the three studies that I've shown you this afternoon. I think we can agree that all people living with advanced illness deserve individualised, sensitive, holistic care. That's our starting point for what we do. However, I think we can improve the care experience of LGBT people if we stop avoiding heterosexuality. We need to look very carefully at the language we use, the materials that we provide, and our communication skills. We need to consider that actually people may have some different or additional needs. So what might this person's need be? We need to think very carefully about them as an individual, whether that's in terms of the family around them, their previous experiences. We need to think about them as an individual with a history and a family and a social context and a sexual identity. We need to think about how we may create some barriers and stresses within that consultation. How does the language we use enable people to disclose their gender identity, their sexual identity to us, and how may we close that down? And we need better visibility of LGBT people within our services so that we can be really clear that if they face discrimination, we have actions and we have policies and procedures which are very clear, very open and very visible, that discriminatory practice will not be tolerated and will be dealt with. So right now, findings from this study are being used. So Catherine Bristow has done lots of dissemination studies. As I said, she's now seen about 600 people around the UK, training clinicians, and our community resources are nearly ready. What's really clear is we do need some further study now. What's come from the dissemination is that staff want help to be able to do this well. There's great willingness to do this well, but there's lots of lack of confidence on how to do it. In terms of dissemination, I have to say one of the most exciting things about this study has been, first of all, the level of community engagement has been remarkable. But what's happened after Access Care has started, and particularly with the support of Marie Curie, has been absolutely incredible. So first of all, the African data was published this summer, presented this summer at the African Palliative Care Association conference. It was very challenging, but it was very well received, and it was quite a powerful moment when Jenny Hunt presented that data in Uganda this summer. An enormous amount is happening in the UK now on the back of Access Care and Marie Curie's other work. First of all, there was a huge amount of national press coverage when Marie Curie published the report Hiding Who I Am, which Access Care fed a lot of data into. There's huge amounts of publicity around that, really, really great press coverage. On the back of Access Care and Hiding Who I Am, a question was raised by an MP to the Secretary of State for Health on what the government's going to do in response to this, which is really exciting. So we're waiting to see what that might be. Later this year, I'm presenting this data to the UK Parliament at Portcullis House, and I'm also presenting it to the Welsh Parliament on invitation, which is great. As I said, Catherine's presented it nationally to around 600 medical care trainees in palliative care, multi-professional trainees. And also the patient and family resource field testing is now complete, and that will be going live soon so that people can download that, and we have another big community strategy to be able to disseminate that. This is the report that Marie Curie published, which drew heavily on the Access Care data. So I urge you to download that. It's a free report and it's incredibly helpful, and there's some nice guidance in there. And lastly, really important to acknowledge, we've got an incredible team. So Matthew Hodson from GMFA, 𝐂𝐈𝐂𝐂𝐂𝐿 from Nottingham, Catherine Johnson, who does LGBT research at Brighton University, Jonathan with his interest in social exclusion, Barb Davison, BWE up in Oxford, who's been fantastic at integrating this data into education, Steve Marshall, who's brought his great social work perspective. We've had Jocelyn Hines, Linda McInhill and Liz Bryan from St Christopher's and the National Council with all their brilliant educational perspectives. Of course, enormously grateful to Marie Curie and also to the Open Society Foundations for the Zimbabwean study. Thank you all very much.